Now, with WPRI.com reporter Ted Nesi.
Welcome to Executive Suite. I'm Ted Nesi, always glad to have you with us. And today we're going to have a really interesting show. We talk a lot about healthcare on this program because it's such an important part of the economy as well as, of course, of people's lives, especially here in Rhode Island where it's become such a big employer. And today we're talking to the man who employs more of those people in healthcare in Rhode Island than anyone else, Dr. Tim Babineau. He is the president and CEO of Lifespan, and everybody knows Lifespan. Tim, thanks for being here.
Great to be here with you, Ted.
So I'm going to start off. I know people at home sometimes can forget which
Sure.
big name of a healthcare group belongs to which. So just remind folks, you guys are a big operation. You actually topped $2 billion in revenue last year. Not profit, but
Correct.
revenue.
Right,
People coming through and everything in 2016 for the first time. Remind everyone what Lifespan encompasses, what you're overseeing.
Sure, great. So Lifespan was formed in 1994 when the Rhode Island Hospital and the Miriam Hospital first came together. Since then, we've added Newport Hospital, Bradley Hospital, and as you know, Hasbro Children's Hospital is part of Rhode Island Hospital, and we most recently added Gateway Healthcare, which is a community provider of mental health. As you mentioned, we're about a $2 billion company. We're the largest employer in the state with a little over 14,000 employees. And we're a very busy place. We do about 250,000 ER visits every year. We do about 40,000 surgeries every year. And about 700,000 patients pass through one of our outpatient clinics every year. So we are the largest and most comprehensive healthcare provider in the state and the region, quite frankly.
That is a lot to oversee. So as we've been talking about, Lifespan's the biggest private employer, which is one of the reasons, though not the only one, your financial situation is always something people keep a keen eye on, not to mention with the other health groups. You were narrowly in the black in fiscal 2016 and continue to be with a bit more even in first half of 2017. How do you feel right now about Lifespan's financial health?
I feel good. I feel good. We're doing okay. As you know better than anyone, it's an incredibly challenging operating environment, both locally and nationally. Healthcare is undergoing some seismic changes, both here in the state as well as in Washington, D.C. and elsewhere. But when I became the CEO 5 years ago, we made the very conscious decision with the support of our board of directors to begin the journey to what I refer to as a complete and integrated healthcare delivery system. When I took over, Lifespan was essentially a collection of extremely well-run, extremely high-functioning, independent hospitals. And
they even had separate boards, right?
They did.
Their own boards.
Exactly right. Separate boards, separate policies. It was a system in name only. And based on my own experience and really some pretty compelling evidence in the literature, we know that the way you really drive quality and control cost, and again, those are our two biggest strategic imperatives: improve the quality of the care we deliver to our patients, and we all know healthcare costs are out of control. The way you do that is by providing care within a complete and integrated healthcare delivery system. So we started that journey 5 years ago. As a result of that, we're seeing our patient experience scores go up, our quality outcomes go up. I'd say we have one of the most engaged and talented workforces in the state. And when you have all those other things, the finances tend to improve. But we've never been primarily focused on the finances. I've always believed if you do all the other things well, you will be rewarded by improving financial performance. And although, you know, year to year there are challenges and we never rest on our laurels, we had a good year last year. We got back to break even, and this year we're doing okay.
You talk about the number of people who depend on Lifespan for their employment, their families. Anytime we talk about healthcare, that's the question I get. What does it mean for jobs? We've seen some of your competitors having to reduce staffing because of the financial challenges they face. What's the outlook for the employee base at Lifespan right now for you?
It's very solid. So the patients are voting with their feet. We've never been busier. Our hospitals, particularly the Rhode Island and the Miriam, are seeing record patient volumes. Our outpatient clinics are busy. So as long as we continue to focus on the patient, make sure we're providing a very high quality care, focus on the patient experience, patients will come. And year over year, our market share increases. Year over year, we get busier and busier. If we do that, we're going to need more people to take care of these patients. I don't see us any time in the near future needing less people.
Well, one of the things, actually, one of my editors mentioned to me, knowing that you were coming on, they've been watching the nurses strike up in Boston, and they wondered, I think that's the first time in more than 3 decades up there, just at one health facility. Do you worry something like that could happen here in Rhode Island, or do you think employee relations are on maybe a better footing than they got up there?
Yeah, the first 20 years of my career, I was a surgeon in Boston, so I know that market well. I know Tufts well. Here's what I will say. It's a sad day in healthcare when there's a strike. There's always 2 sides to every story. I don't know the details of what happened with Tufts. Nobody wins in a strike. And it's unfortunate. I've been following it as you have. I would say we have very good relations with all of our nurses, those both represented by organized labor, those that are not represented by organized labor. So while it's always a concern, I don't see that as a real, it doesn't keep me up at night worrying these days.
So we have to talk, you mentioned the changes happening in Rhode Island healthcare. I sometimes joke that covering hospitals, lifespan care, it's like the Red Sox and the Yankees. And I've said that to Dennis Keefe too, and I won't say which one is which because I don't want to get either of you mad. So big headline at the moment, obviously, is Women and Infants Parent, C&E, Care New England, this proposal to merge with Partners Healthcare. You folks had put forward your own offer to join up with Care New England. At the moment, they've decided to go to the Partners deal. Candidly, is Lifespan going to fight the Partners deal? Are you just saying, all right, do your thing and we'll do our thing? What's your view at the moment on that?
We could dedicate a whole show to this topic. I came to the state 9 years ago with the promise of a Care New England and a Lifespan merger. It's one of the things that attracted me away from Maryland here. The merger has always made sense. It continues to make sense. I've been very public about saying that I believe a merger between Care New England and Lifespan would be good for patients, would be good for the state, would be good for the economy, would be good for healthcare. For reasons that are known only to them, they appear to be headed in a different direction at the moment, and they have their reasons for doing that. We're going to continue to focus on what we've been focusing on over the last 5 years that has made us successful. Continue to focus on quality, continue to focus on our patients, continue to focus on, again, what I refer to as continuing the journey to become a complete and integrated healthcare delivery system. At the end of the day, we're responsible for taking care of the patients in this community, and sometimes the merger mania, as I refer to, can become a distraction, and you end up taking your eye off the ball of what your real mission is, and our mission, delivering health with care, is what we'll remain focused on, and the chips will fall as they might.
Now, listening to you there, I hear you said it still makes sense, and they haven't signed anything yet, Partners and Care New England. If something were to happen, I'm not predicting that, but if somehow the Partners deal did not end up coming to fruition, would you still be open to talking to Care New England about a future together? Is it too hypothetical?
Well, I'll tell you exactly what I told Dennis when he called me to say they're going to go in a different direction. I told him, my door is always open. My door is always open.
All right, I'll let you guys chew on that during the break. And when we come back, we're going to talk much more with Tim Babineau about the changes in the healthcare sector, some work they're doing on opioids, and much more. Stick with us on Executive Suite. Welcome back to Executive Suite. I'm Ted Nisi, and we're talking with Dr. Timothy Babineau. He's the president and CEO of Lifespan, the parent of Rhode Island Hospital, the Miriam Hospital, Newport. What am I missing there?
Bradley, Hasbro Children's.
There we go. And then physicians groups and a lot of other stuff, and the biggest private employer in Rhode Island. We're talking about, I want to ask one more on the internecine back and forth in healthcare before we move on to some other topics, which is the obstetrics plan, which has been getting a lot of headlines. You're proposing, your company, to open a new obstetrics unit at Rhode Island Hospital. Care New England says we do that across the street at Women and Infants. Why should they have that? It might be overlap of services. What's your argument? What's your case that you think it would be good to have both of those?
Sure. It's not so much having both of them, but again, I feel more strongly than ever, and the evidence would suggest that when care is delivered within a completely integrated healthcare delivery system, quality goes up, and that's the way you control costs. A big missing piece of Lifespan's portfolio is obstetrical services in downtown Providence. Again, we made no secret our preference would have been to find a way to have women and infants come into the fold. That doesn't seem to happen. Models of care are changing. Women are getting older. Women are getting sicker. And we believe strongly that if we want to go to the state of Rhode Island and the region and say, if you come to Lifespan and receive all of your care within our system, primary care, specialty care, inpatient care, outpatient care, Your outcomes will go up, and we'll be able to control the costs. The thing that's missing in our portfolio for us to do that is obstetrical services in Providence. That's the reason. I'm not trying to diminish women and infants in any way. This is not an attack on women and infants. I know people would like to believe otherwise. That's simply not the case. We have a mission. Our mission is to take the best possible care of patients that we can. And we believe adding that to our portfolio in Providence will really get us where we need to go.
Well, now we'll turn to something where you're lined up right with your fellow hospital executives, which is the big federal health care bill that's being discussed down there. Just this morning, actually, there's a new draft out on there. One of the things they're looking at, the congressional leaders, is potentially reducing future Medicaid funding, having the growth not go up as high. Medicaid, huge in Rhode Island, more than $2 billion a year, hundreds of thousands of people on there, a lot of hospital revenue tied to Medicaid.
Right.
I have to believe you're concerned about some of the proposals.
Right. It's a great question. And what I would tell you listeners is, as you listen to the debate, if you can follow it in Washington, the issue that they should stay focused on is exactly what you suggested, the federal match for Medicaid funding. When the Medicaid expansion happened in Rhode Island, patients benefited, no question. They had better coverage, and we benefited because patients that previously had no insurance at least had Medicaid insurance, so our finances improved. As the feds think about sending less money to the states for the Medicaid program, it will be harder, particularly in Rhode Island that has its own set of financial challenges, to backfill that money. If they can't backfill that money, coverage may go down, coverage may be limited, what we get paid for Medicaid would go down. All of that has a really adverse effect on both our patients and our finances. So it's an issue we're following very closely.
And Medicaid, I mean, usually when I talk to healthcare execs, you're not usually super excited about the reimbursement rates that exist and the amount of money coming in Medicaid anyway. I've heard repeatedly that at least some parts of Medicaid don't necessarily cover costs. Yeah. So would you be, rather they be looking at more Medicaid money going in the system rather than less? Do you think more is needed?
Well, again, getting paid 65 cents for a dollar's worth of charges is better than getting paid 0 cents for a dollar's worth of charges. So again, when folks have Medicaid, we're at least getting something. We are, Rhode Island is a very hard operating environment for healthcare. Our book of business in a $2 billion company is about 65% government pay. That's broken down into about half Medicare, half Medicaid, and about a third is commercial. The way to think about it, the way I think about it, because I try to keep things simple, is we about break even on Medicare, not quite. We lose money on Medicaid, but something's better than nothing, and then you eke out a little bit of a margin on the commercial insurance. So look, if someone has no insurance to have Medicaid, we'd much rather they have Medicaid. But one of the things I hope we have a minute to touch on is this notion of OHIC and commercial caps.
Well, let's go right to it, because that was actually my next question. OHIC is the Office of the Health Insurance Commissioner. Right. Rhode Island, the only state with a health insurance commissioner, right. Health insurance specifically, and they have put in some hard caps on how much the hospitals can get from the insurers, so it's kind of secondarily goes to you. I know they gave a little relief on that at the start of 2017, but I've talking to Care New England, as they've gone through their challenges, they repeatedly say they have big concerns about that. Sounds like you share those? Yeah,
I do. Again, a couple facts are irrefutable. Healthcare is too expensive. Healthcare is too expensive. But the way we go about fixing it, I think we have not focused on the right thing. Small businesses are getting killed. And I think one of the motivations for OHIC to put the caps in place was that they thought eventually that would translate into lower premiums for small business providers. Unfortunately, I don't believe that has happened. The data is really sketchy on whether the intent of OHIC and what they hoped would happen has in fact happened. To me, it's a little bit like putting a tourniquet on below the bleeding, okay? You may feel better because you put a tourniquet on, but the bleeding's still happening. We're focused on the wrong problem, and the unintended consequence is it makes it harder and harder for hospitals to reinvest in capital, reinvest in the property, plant, and equipment, and employees. Every healthcare system that has gone out of state looking for a partner has done for one reason and one reason only: access to capital. They need money. Depending on what happens with Care New England, depending on what happens with the other healthcare systems, it is entirely possible Lifespan could be the only remaining healthcare system in the state that is locally owned and operated, where the decisions are made here in Providence, that is locally governed. In order for us to continue to do that, we have to have solid finances. We're not asking for OHIC to go away, but there needs to be a little bit more reasonable approach as to what we can go to the commercial insurers and say, we need a little help here.
Briefly, because we have to go to another break, you were on that commission a few years ago that some people on the commission thought there should be fewer hospital beds. You, Ed Quinlan, who was at Hari at the time, and some others had a different view on that. What do you think right now? Do we need fewer hospitals, fewer hospital beds to make it work for the ones to keep the bigger ones strong?
Well, again, we could spend a whole time
I know, these are some big questions.
Well, I can tell you that at Rhode Island, the Miriam Hospital, we need more beds. I mean, we need more beds. We are jammed. Some of the other hospitals that may be at half capacity, it's whether you're looking at the healthcare system as a whole, or I think some rationalization of beds makes sense. Of course, no one wants to give up their beds. Right. But we really need more beds within the lifespan system because we are so busy.
Interesting. All right, we're going to take a break. We come back, we're going to talk about another big new initiative at Lifespan. It's called the Life Chart, and we want to find out if having these records go across the system is doing any good so far. Stick with us on Executive Suite. Welcome back to Executive Suite. I'm Ted Nesi, and we are talking today with Dr. Timothy Babineau. He is the president and CEO of Lifespan, the owner of Rhode Island Hospital and a host of other healthcare organizations. It's the largest private employer in Rhode Island. And a big initiative, I feel like I was getting the press releases about it for years at Lifespan, was this thing called Life Chart. And it is a single electronic health record, as I understand it, for the patient. Spans the system. So you start in Newport, you come to Rhode Island, you get the same record going between the docs in the different places. Now, I have a tiny bit of skepticism only because I feel like reporters have been hearing this is going to help. These electronic health records are going to be big cost savings, et cetera, for years, and yet it's always in the future.
Sure.
So what are you seeing so far from this? Is the payoff going to be there?
We're beginning to see it. You're absolutely right. An EHR, or electronic health record, in and of itself is not a magical tool that's going to fix all the ills. It's how you use it. Probably the single biggest and smartest decision we made at Lifespan, with the support of the board, was to invest $120 million of our own money to create one single health record across the entire enterprise. As a practicing surgeon, I can used to practice. The hobgoblin of quality and cost is fragmentation and miscommunication. And that's what plagues many healthcare systems. Now that we are on a single record, where irrespective of where the patient is in the Lifespan system, inpatient, outpatient, Newport, mental health, every one of their providers can see that information. We've seen our quality go up. We've beginning to see our ability to control costs. Why? Because we're not doing 3 CAT scans because the guy can't find the one that was done in Newport a month ago. Because we're not duplicating lab tests because they can't find the paper slip of the lab. So it was a big, hairy, heavy lift for us to do it.
Because that's a big it's $120 million. That's a big capital.
Well, and it was
investment.
A 20-month prep process, and we're now just 3 years past the go live. And we are now really beginning to leverage that asset. Our quality is going up, and we're getting a handle on our costs. So if you use it correctly, you have one health record, and we're the only healthcare system in the state and the region that has that, you can really see some nice returns.
So no doubt in your mind it was the right decision.
Zero. I would say it's the single best decision we as a company made in the last 5 years.
Interesting. Okay, well, you're watching that, and I hope I don't have to use one anytime soon since I'm in the hospital.
But if you do, know that everybody can see your information. All the appropriate people can see your
information.
Exactly.
So another initiative I wanted to ask you about that I found interesting. Lifespan, you just recently in June 2017 opened it's called the Lifespan Recovery Center. It's at Rhode Island, I think, Rhode Island Hospital. And it's to provide treatment for opioid abuse. Now, nobody doubts, everyone knows what an enormous problem that is. Obviously, your hospitals, I'm sure, were already dealing with opioid abuse before you opened this. Why did you decide you needed a single clinic to handle that issue as opposed to, I suppose it must have been a little bifurcated before that?
Yeah, the opioid epidemic is tragic, it is heartbreaking, and it is an epidemic. I mean, you know the numbers. More people die from opioid overdoses than car crashes and cancer combined. It's awful, and it's only getting worse. We at Lifespan treated a piece of the puzzle, but we weren't treating the whole puzzle. So if you came to our emergency room with an overdose, we'd treat you while you were there, and then quite frankly, there wasn't a lot to offer you once you left. We had some recovery coaches and some other things. So we felt strongly we needed to expand how we took care of this really important population. We needed to remove the stigma that it's only poor people that do this or a certain demographic. It affects everybody, all demographics, all walks of life. So in a lot of places, these treatment centers are in the basement. We built a brand new state-of-the-art treatment center that is modern, is clean, is right there on the street in front of everybody, because it's a big piece of when you left our emergency room, we didn't have a lot to offer you. Now we can say, we can see you tomorrow at the Lifespan Recovery Center. Let's continue the progress we started here in the emergency room.
So it sounds like, unfortunately, you don't see any diminution in demand for those services right now.
Unfortunately not. And again, not that it's the only thing, but reimbursement's a challenge. We don't often get paid for those services, but we feel so strongly, based on our mission, we're responsible for the health of our community. And even if you don't get paid for something, sometimes you just have to do it because it's the right thing to do. And that thing has been open about a month, and fortunately or unfortunately is already incredibly busy.
Wow. Gosh, hopefully you find the demand goes down.
I'd love to be able to put it out of business
in a
few
exactly,
years.
to close it down.
Yeah.
So I want to ask you a totally different question. So before you were a hospital executive, you actually referenced it earlier, you were a surgeon,
I was.
real surgeon. You cut people open, doing the whole thing. Do you ever miss that?
I do.
Now
I do.
you're at a desk all day and having me ask you nasty questions about your finances.
No, I joke. When I was a surgeon, at least everybody told them, did exactly what I told them. That doesn't happen. Yeah. I love my days as a surgeon. I was one of those weird little kids who knew they wanted to be a doctor when they were 5. My dad was a doctor. My mom was a nurse. I used to carry his black bag up the walkway.
Had the toy stethoscope.
Yeah, exactly. I loved it. But I wanted a new challenge. As I say to my dad, I used to take care of patients one at a time. Now I take care of them by the tens of thousands at a time. But I do miss being in the operating room.
Do you have a hardest or most memorable? Do you have a surgery war story you like to tell when you think back to those days?
I used to take trauma call. So the gunshots and the knives, in the middle of the night, and those folks didn't see it coming. So those were some of the more challenging, but also some of the more rewarding cases.
Do you ever go down and watch your surgeons now and what they're doing, or decide I don't know, move a little over to the side or something?
I do. I walk around the hospitals, and I poke my head in the OR just to say, there's a tinge of jealousy that I can't don the mask and the gloves and the garb, but I never criticize or comment.
That's probably smart, especially they might have a knife in their hands.
Exactly.
So we only have about a minute and a half left.
Sure.
So going back, zooming out to the big picture, you referenced something that I also find really interesting, which is we are getting toward a situation where Rhode Island might not have any locally owned hospital systems, but yours, depending on how South County's talks with Yale go.
Yeah.
Do you think generally we're going to look back and regret that, or do you think this is just the way of the world? You said people need capital.
Yeah.
There's a sense of bigness being necessary now. Do you think we're just going to find this was just going to happen everywhere?
I think it's and it's not either or. I think as I've said before, Rhode Island deserves at least one complete and integrated healthcare delivery system. Massachusetts has 5. Connecticut has 4. Rhode Island has 0. So we deserve at least one. And then if the rest of the healthcare system needs an out-of-state partner to do, that's fine. So it's not either or. But we feel very strongly that having the control local, again, fragmentation is the hobgoblin of quality and cost, and having out-of-state partners just increases fragmentation. Having it here, contained, locally owned and operated, not just as a power trip, but we know that improves quality and it controls costs.
All right, Dr. Tim Babineau, we have to go, but thank you so much for joining me. Hope to have you back. And thank you for joining us for this conversation about healthcare. Again, Dr. Tim Babineau, President and CEO of Lifespan. If you missed any of this episode, you can get the whole thing on our website, WPRI.com. You can also catch it as a podcast on iTunes. We'll see you back here next week on Executive Suite.